We have no expectation to see you on Monday.
So we can come in and do group study if we want to.
Y'all more than welcome. Let me see here. I think first year, no, second year doesn't have anything on Mondays. Yeah, you can come in and hang out. Uh, yeah, we'll start at 9:30. If that's when you all tell me, if y'all want to start at 9:30 or 9, I mean I'm here at 8, so it does, my timing doesn't change. So y'all pick the time. I'll let y'all give me the time. I'll be here. Okay. So I want to go back, make sure I hit the classification of joints part. Monday I was feeling kind of weird. I don't know what was going on. I was having some nausea stuff. So just trying to get to the end of some things, but I definitely want to go back and review that so that we can get the classification of joints. We're going to kind of breeze through chapter 4 to get to where I really want to be, which deals with how joints move. And that's going to be the big thing that I want to cover today. So down at classification of joints, that's kind of where we'll start on today. The book tells us joints, they're classified in 3 ways: the type, the shape, and the function. Type, shape, and function. If you look on the next page, table 4.1, it'll have the type and the functions associated with it. So some of these are going to be relevant, some will not, but I do want us to definitely kind of go through these so it'll make sense. So there are going to be 3. So let's go through it. Let's keep going through it as it states. It says the type of joints are described as synarthrosis or synarthrodal. So we used to call them synarthrodal, or diarthrosis or diarthrodal. Synarthrodal are subdivided into either fibrous joints or cartilaginous. There are several fiber and several cartilaginous. Their job is to provide stability, whereas diarthrodal will provide mobility. So synarthrodal, stability, and we'll make that make sense. Diarthrodal, mobility. So when we deal with stuff that's a synarthrodal joint, it's going to be stable. It's going to try to hold things together to keep it from shifting around. Whereas diarthrodal will help to provide movement of structures. So synarthrodal, stability, diarthrodal, mobility. So it's this one type of fibrous joint that we can look at are called sutures. So of the different types of fibrous synarthrodal joints, we have sutures. This is what we find here. So they are synarthrodal joint. We'll primarily find them on the structures of the skull. If you are able to see a skull somewhere, the cap of a skull. Yeah, here we go. So when you look at the cap of a skull, you'll see some lines that run vertical and horizontal. Those are sutures that help to stabilize the small bony compartments of the skull to help hold the brain in. So in babies, that's not ossified yet. It's very soft. That's why they tell you don't poke a baby's head really aggressively, because you can cause skull fractures, because their skulls aren't very stable yet. They have to grow into the stability. So sutures help with that. So they are a type of synarthrodal fibrous joint. So that's one, the sutures of the skull. Ligaments are types of synarthrodal fibrous joints. We have different ligament types all through the body. The one that the book points out is the distal tibiofibular ligament. It's found here at the bottom part of the leg, right before the ankle, and it holds together the bone of the tibia, the large bone of the leg, and the fibula, which is the small bone of the leg. So it's a distal tibiofibular ligament that helps to hold that together. So that's another type of synarthrodal fibrous joint. So ligaments in general. And then interosseous membranes, which tib-fib have an interosseous membrane right here in the middle. So that light color here in the middle is an interosseous membrane between the tib and the fib. We also have one between the ulna and the radius, which are the 2 bones of the upper extremity. So my ulnar and radius has an interosseous membrane, and its job is to provide stability to the bones to keep them from shifting too far away from each other. So we need that interosseous membrane that helps us to provide stability. So again, so we have sutures of the skull, senile throttle. We have ligament components with distal tibial fib and all kind of ligaments throughout the body. It's not just that one. All the ligaments of the body form a ligamental stability structure. Ligaments help to hold bones together. And then we have interosseous membranes, which help to hold bones together, keeps them from shifting. Again, we find that in the forearm and we find that in the lower leg, tib, fib, ulnar radius. And then we have the gum phocis joint, which is a synarthroidal fibrous joint, which helps to hold our teeth in place, which is why if you ever have to have a tooth removed, the technical term for that, or the terminology we would use for that, that's medical terminology, is a tooth extraction. So that's what the dentist writes up so he can charge you a whole lot of money to do it. Tooth extractions. Anybody here ever have a tooth removed since you were an adult? So, okay, yeah, there we go, a couple of people. So as a kid, it's easy. Tooth gets loose, somebody holds it or someone ties a string around it. I remember as a kid, my grandmother tied a string around a tooth and slammed the door. We were abused as kids. Y'all didn't grow up in that generation. People didn't care about your mouth. But however it comes out, it's very easy to pull out. As an adult, they have to literally hold your head and grab on, and I mean, it's a fight to get a tooth out of your mouth. And the reason why is your teeth sit in a socket called a gum phocis joint that helps to hold them in and lock them in place. So again, when it's dealing with synarthroidal fibrous joints, their job is to provide stability. So the big thing is just to know, if we have it on the exam, I'll put maybe a photo up and I'll say, what type of synarthroidal joint is this? So you'll have to know if it's a gum phocis, if it's an interosseous membrane, if it's a ligament, or if it's a suture. So you may see photos that deal with that on the exam. Cartilaginous joints on the other side provide stability while allowing a small bit of motion. So these are going to be joints that help with a little bit of motion, but they also help with more stability than motion. Probably one of the most relevant types of cartilages that we deal with in the body will be the cartilage between our vertebra, so our intervertebral discs. That's going to be some of the main cartilage. We won't go into which type, but they are a type of fibrocartilage. The same thing is also found in the knee. Your meniscus in the knee, the top parts of the knee, they're fibrocartilage. We'll get into that later. And then there's other types of cartilage, hyaline cartilage that we can find, the nose, the brim of the nose, the trachea, those things. So there are all types of cartilages of the body, but they are a type of synarthroidal cartilaginous joint. The rib cage as well is a synarthroidal, have synarthroidal joints. The actual connection, the sternocostal joints here, that the white parts here called sternocostal joints that connects the ribs to the sternum, sternocostal joints. They are examples of cartilage that helps, again, to provide some mobility, but a lot of stability. Then we get to diarthroidal joints. That's going to be the joint that provides the most mobility. These are going to be joints that really help us to have mobility and to perform actions. So the book tells us diarthroidal joints are normally referred to as synovial joints. They're usually called or termed synovial joints. And the reason they're called that is because they have a synovial membrane that lines the joint that helps to do some very specific things. We're not going to cover it all the way right now, but we're going to cover it a little bit further down in the book in the same chapter. So we'll talk about what makes it a synovial joint. But the book says synovial joints, number one, have no direct union between the bone ends. So that means it's not that bone is fully attached to bone. In some cases, bone will be attached to bone. The elbow is one of the cases where that does not hold true, because your elbow, you're going to have an actual bone-on-bone connection forming the joint, which is why you have a hard infield. It's bone connected directly to bone. But in most cases, when we're dealing with diarthroidal or synovial joints, there's no bone-to-bone connection. And the reason why is, if we have bone connected to bone, the more we use it, the more we're going to irritate it. The more we irritate it, the more it gets inflamed. The more inflamed it becomes, the more problematic it is. When bones consistently rub on bones, they're going to start to cause problems, and ultimately we'll need to have replacements done. That's why we get joint replacements. In our shoulders, the bones are starting to rub against the other bone. In our knees, in our hips, in our ankles. So that's when bone rubs on bone. So we don't want bone on bone connection. We want there to be a space between the bones so that they can move as they're designed to move and not cause problems. So that's one of the big things. There's no direct connection. There will be a capsule surrounding it. We talked about that the other day. So there's always a joint capsule. We showed you that with the skeleton over there on the elbow and on the hip. There's a capsule that surrounds the joint. The capsule is going to then have, the outside of the capsule is going to be fibrous, which serves as a protective mechanism. The inside of the capsule is going to be lined with synovial membrane or synovial lining. So outside is fibrous, which means it's going to be hard and durable, which is going to prevent damage to the joint to the best of its ability. Whereas the inside is going to have a lining of synovial membrane. And the synovial membrane's job is to secrete or to produce synovial fluid. And synovial fluid to a diarthroidal synovial joint acts just like blood does for the rest of your body. So blood serves as a nourisher for your body. If you don't have blood flow, you tend to die. There's nothing else we can flow through your body that's going to keep you alive other than blood. Blood keeps us alive. Same with the joint. The joints, these diarthroidal synovial joints don't get great blood flow to the joint itself. So the way it gets nourished is through the synovial fluid. So synovial fluid acts as a cushioner, but it also is it acts as a cushioner on one end, but it primarily acts as a food source or a source of stability and provision for the joint to help to keep it healthy and alive. So it keeps it from breaking down. So we need the synovial fluid to stabilize the joint. So it serves, it's almost like blood for the joint, because there's no direct blood flow going into it. So the book tells us the same thing. The outer layer of the capsule is strong fibrous tissue, which provides stability. The inner layer is lined with synovial membrane that secretes the synovial fluid. And then each bone will be covered with an articular cartilage. So the bone ends will be covered in articular cartilage. See if I can't hunt down a bone with some articular cartilage on it. Of course, it would be miserable to find. Here we go. All right. So, here we go. This is a good model. So, yes, so the bones of the joint will be lined with articular cartilage. And so that's the blue stuff that you see here on this model. That's articular cartilage. It covers the joint and it allows for joint surfaces to move smoothly on each other. So that's what gives us smooth, normal motion, articular cartilage. Yes, sir?
When they do a base coat, do they take
Depends on what they find. So when they scope a knee, what that means is they're going in to do an observation of the knee to figure out what's causing it pain. So they're trying to see, the knee is one of the least stable joints in the body because it's held together only by ligaments. Like it has no direct bony concepts. Ligaments hold it together. And so they're going in to find out, is it a cartilage problem? Is it a meniscus problem, which is underneath that? Is it a ligament tear? They're trying to find the structure. Most times it's going to be a meniscus tear, and they'll go in and clip the meniscus, the inside part of the knee. They'll clip it to clean up the knee so that it allows for smooth, normal motion again. So usually it's some kind of meniscus, a little small meniscus tear. And you can tear them easily. I tore mine playing pickup basketball, which is why I stopped doing it. Silly kid was under the basket and they were losing, and he was mad that his team was losing. I don't know why. I'm feeling like I'm ridiculously dumb and can't get this back on there. But their team was losing and he was angry, so he decided, while I was going up for a rebound, to stick his leg under my foot coming down. And so my foot came down on his foot and it twisted my knee and tore my meniscus. So you can tear them really easily. And so, no, I did not have a repair. I had ACL surgery on that knee, so it's going to stay that way until the Lord either calls me home or I have to get it replaced. Not doing it. So, easy to tear. So that's what happens. Those are the functions of a synovial joint. So definitely we'll want to know that. That's going to definitely show up on the exam. So a synovial joint has several components. One, a capsule. So we're going superficial to deep. So we're going superficial to deep when we're discussing the capsule. Know that it's fibrous. Protection is its function. 2, synovial membrane. Function, secrete synovial fluid. 3, synovial fluid. Feeds and protects the joint. Then 4 is the articular cartilage, which covers the ends of the bones of a joint. So those are the 4 main components of a diarthroidal / synovial joint. So if we're using diarthroidal, it's exactly the same as using the word synovial. Okay. And there's a great video inside of the PowerPoints that's really good, that'll walk you through it. I don't know if we won't cover it today, but you can look at it. It's a really good one that goes through the different joints. Okay, so the book then tells us synovial joints, page 47 at the top, are further classified by the number of planes within basically a synovial joint is further classified by the number of planes and axes in which a joint is allowed to move. Let's just make that terminology simple. So the number of planes and axes a joint is allowed to move gives us even more detailed information about the type of synovial joint we're dealing with. So not all synovial joints are as cool as the shoulder and the hip, which is a type of joint that gives us free movement in all different planes and direction. Some joints only have very small amounts of motion, and so we'll go through those. So it says the anatomical shapes of the bones will determine the number of planes and axes that it moves within. The first kind we deal with are non-axial joints. It says the joint surfaces are usually flat, and all they do is they glide on each other. So they just slide on each other. Forward, backwards, up and down, they just slide on each other. They don't have dynamic movement like the shoulder, just gliding back and forth, just sliding back and forth. One of the primary ones where we have this are the joints of the hand. We call these the carpal bones. So the bones of the carpals, the bones of the hand right in here, there's a joint. These are joints, but they don't have dynamic movement. They just slide on each other to help movement to occur around them. So it's a non-axial joint. Very little, no motion as it relates to dynamic movement of the joint. So a non-axial joint does not move in any plane. So for it to be non-axial means it does not move in any plane. All it does is just glides and slides. It doesn't move in the frontal, it doesn't move in the sagittal, it doesn't move in the transverse. All it does is glides and slides on the other bones that's connected to it. So it doesn't move in any plane. That's why it's non-axial. It doesn't move in a plane or axis. It doesn't move in a plane or about an axis. Let me say it that way. It does not move in a plane or about an axis if it is a non-axial joint. No plane, no axis, non-axial. Uniaxial joints means that they move in one plane of motion. So they'll only move in the frontal plane. They'll only move in the sagittal plane, or they'll only move in the transverse plane. We have several of these uniaxial joints in the body. The elbow is a type of uniaxial joint. We call it a hinge joint. It's a uniaxial hinge joint. It only moves in the sagittal plane. Your elbow only flexes and extends. If it does anything else, you have a very strange elbow. It only flexes and extends. It's a uniaxial hinge joint. Only flexes and extends. Only moves in the sagittal plane. Then we have a pivot joint. It's going to be the joint of your proximal forearm. So you have a proximal forearm, which is up here by the elbow, and then you have a distal forearm, which is down here by the wrist. The joint of your proximal forearm is a pivot joint. The only motion that is permitted to have is pronation, supination in the transverse plane. That's all it does. Pronation, supination. Doesn't do anything else. Doesn't flex, extend. It doesn't abduct. It only pivots. Rotation. So it's the proximal forearm joint is a pivot type joint. So they are both uniaxial joints. Biaxial joints means the joint moves in only two planes. So it moves in two different planes. So it moves in two different planes. Not three, but only two. The joints of the fingers, not the ones of the wrist. Not these, not the ones of the wrist. We talked about those earlier. Those are non-axial of the wrist. The ones of the fingers and the toes, they are of fingers. Yeah, fingers 2. Let's just talk about fingers 2 through 5. 2, 3, 4, and 5. These 4, they are biaxial in their nature. They flex, extend. So you should be able to do this. This is how you make a fist. And then they also ab and adduct. When I was a kid, Star Trek used to be on and everybody wanted to be Spock and do this cool. I know, I'm old, don't worry, you'll get there. We'll talk about the thumb. If I include the thumb, it's gonna make what I'm going to say next, it's gonna confuse you. So don't think of the thumb as that yet. Because you're gonna go, what? You just lied and said the thumb was, so don't think of the thumb. Just think of digits 2 through 5 as biaxial. Flex, extend, ab, and adduct. So they are biaxial joints. There are some joints, there is a couple of joints in the body that are biaxial, but they have a really cool functional motion, and we call them cellar joints. Cellar joints. So they're still biaxial in their function, but they move in a lot of different ways that almost will look like a triaxial joint. The main cellar joint of the body is going to be the joint of the thumb, the first digit. So it's not the actual finger movement, because finger-wise, it only does the same thing as the other fingers, flex and extend, and ab and adduct. But the cellar joint is actually here in the long bone of the thumb, and it allows for it to do something called opposition. And we'll get there. So we get to do cool stuff with the thumb. And it's called a cellar joint because the joint itself is shaped like two saddles. So if you've ever ridden a horse, this looks like a saddle that you would put on a horse here, and then this is an upside down saddle. And so the two of them combine together to create a saddle joint or a cellar joint. So a lot of years we called it a saddle joint growing up, but it is a type of triaxial joint. For all of my years as a student, it was called a biaxial joint with just extended abilities, but now they're starting to list it as a triaxial joint, meaning it moves in all three planes. So when something's triaxial, it moves in all three planes. So that joint flexes, extends. So that's thumb flexion extension using that joint. This is thumb ab and adduction using that joint. And then thumb opposition, which is a rotation, which is in the transverse plane. And then the main triaxial joints of the body are going to be the ones of the shoulder and the hips. Shoulders and the hips are your primary triaxial joints, and they will be ball and socket, meaning it'll have a head like a ball, and then it'll have a socket that it fits into. So your ball and sockets, primary things. So only thing from table 4 to know the shape of the joint that we talked about. If it's non-axial, uniaxial, bilateral, the shape, and then if it's non-uni or biaxial. You don't have to know the motions to them yet. We'll get through that sooner or later. And you don't have to know. It's good to kind of remember some of the example joints that we talked about. Okay, so structure of a joint. Let's dive into this so we can get what we want to get to today. So structure of a joint. It says many structures are associated with synovial joints. Bones, there are usually going to be 2. There are some joints where we have 3, but most of the time, some structures we have 3 or more, but primarily for the most part, it's going to be 2 bones that articulate with each other. That word articulate is a fancy word for connect, but not directly. So they're going to approximate, but not directly connect. So that's what articulation means. It means it's not that it's sitting inside of something all the time. They just connect. The amount and direction of movement allowed is dictated by the shape of the bone ends and the surfaces. Ligaments are fibrous connective tissues that hold joints together. So ligaments surround joints and provide stability to it. We talked about that already. They are flexible but not elastic, meaning they have a little bit of give, but they're not elastic where they have tons of give. The more give a ligament has, the more damaged the joint is and the easier it is for it to tear. So you want ligaments to be tight. The word we use there is taut, but they should be firm and stiff, but not very giving. Okay? It says flexibility allows joint movement, but non-elasticity keeps it in close approximation. It also provides protection to the joint when it's non-elastic. Ligaments permit appropriate movement for the joint function while preventing excess joint motion. It says every synovial joint will have a joint capsule. We talked about that surrounds and encases the joint. We've shown you that. A joint capsule's outer layer is fibrous. We just talked about that. Often it's going to be reinforced with ligaments. So there are going to be ligaments that will attach to it to help hold that capsule in place to protect it. So the capsule's job is to support and protect. Then you have the synovial membrane, which is deep to the capsule. It's going to be a thick vascular connective tissue layer that secretes synovial fluid. So vascular meaning it has blood flow running to it, even though the cartilage in the synovial fluid does not have blood flow running to them. So the membrane does, but not the other stuff. Synovial fluid is a thick, clear fluid consisting of water and dissolved proteins. There are two main functions. One is lubricating the articular cartilage that surrounds the joint. So it's going to help to lubricate the joint. And so that's what the light blue fluid inside of the knee here represents. Its job is to lubricate this articular cartilage, almost like a motor oil does to parts inside of your motor. It helps to lubricate it. So that's one of the things that it does. And then the second is it's a source of nutrition for the articular cartilage. So it supports it. Because again, articular cartilage has no direct blood flow. It doesn't have blood flow going to the articular cartilage. So the nutrition to the articular cartilage comes from the synovial fluid. Now, why is that important? I know you keep saying, why is he harping on that? Ah, God, he said it 9 times. Why is it important? I'm glad you asked. Because there is no direct blood flow to the articular cartilage, when it is damaged, it cannot repair itself. So blood flow to areas allow for repairing of tissue. So your blood to different parts of your body will help to repair itself. But because this articular cartilage doesn't have blood flow going to it, but only synovial fluid supporting it, it can't repair itself. Therefore, when the joint starts out looking like this, y'all young, healthy, kneed people, if we took an image of your knee, an MRI, it would look like this, will ultimately turn out looking like this, sometimes in your 70s and 80s. And it will need to be repaired or replaced because the articular cartilage surrounding the knee can't repair itself. So damage to the knee over the years wears it out. It'll wear out. Articular cartilage is going to wear out. Yes, ma'am?
So what if you have none? So what if you have none?
No.
I had an accident. They had to take all of it out to stitch it back up.
They probably didn't take all. They probably took a good amount. Yeah. So the joint wears out faster if you are doing things to wear it out. So which joint is in your knee?
Yeah.
So I would encourage lots of activities that does not require a lot of weight bearing and a lot of stress on the knee. So not a whole lot of deep squatting, not a whole lot of running activities. You don't want to start becoming an ultra marathoner in your 30s because you already have low cartilage in the knee as it starts out. So you want to do things like biking and swimming, things like that are knee protective. And so, yeah, you can take care of cartilage. Just have to be smart. So take care of what you have left. Good question. Glad you know that. Yeah. So I have a piece of taken out of mine. So the synovial fluid is what feeds the articular cartilage. Once it's gone, it's gone. So there is no process in the world right now that we found. Well, they're starting to experiment with some things. They can do what's called a partial knee replacement. But there's not a lot of not a lot of well-developed research processes outside of surgery that's going to repair articular cartilage. So, they can give you injections in it to calm down the inflammation and do a lot of cool stuff like that, but nothing has been found to repair this articular cartilage that covers the end of bones. So once it's gone, it's gone. That's why we have to take care of it. Okay. So the book goes in and talks a little bit about cartilage. The only one that we'll talk about is hyaline cartilage. It says hyaline cartilage is what covers the end of the opposing bones within a synovial joint. With the help of the synovial fluid, it provides smooth articulating surfaces. It lacks blood and nerve supply. Highlight star, highlight star, highlight star, because it's getting you to exactly what we were just saying. Has no blood or nerve supply, which means when it's damaged, it's damaged. There is no fixing it. And so because of that, nutrition is only provided by the synovial fluid. It cannot repair itself when it is damaged. That's the danger of messing up hyaline cartilage. Okay. We'll get to the other types of cartilage in other parts. Okay. We'll talk about tendons and things like that when it's relevant. Bursa. Let's talk a little bit about bursa. Bursa are cool because you have bursas all around the body. Okay, so bursas. Bursas are small fluid-filled sacs located near many joints. They're lined also with synovial membrane and synovial fluid, and their job is to provide cushion and reduce friction between tendons as they are moving through their functional movement around the bones. So you want something to cushion certain parts of the tissue or a certain part of a tendon where the tendon is going to be rubbing against the bone. And so you need something to serve as a buffer so that that tendon rubbing against the rough surface of the bone doesn't tear the tendon. And so bursas help to do that. I think there's like 23 different bursas all over the body. We're not going to have you know that number or know all of the names of them. Just know that they are relevant to help prevent friction. So the blue things that you're seeing on the screen here are types of bursas. So all of the blues are bursas. So they cover tendons, and they either cover the tendon or they are positioned where a tendon is going to move to prevent the tendon from rubbing against the rough surface of a bone and tearing. So that's the goal. If it keeps rubbing against it, it's going to tear. So we need bursas. And that's what the book tells us. Repeated movement will cause excessive wearing of a tissue. The bursa, which they're talking about subdeltoid, would reduce the likelihood of damage. So there are lots of different bursas. I want to say there's 23 different bursas all throughout the body, or if not a little bit more. So, okay, so good stuff. All right, so that's a good place to take 5, and when we come back, we're going to skip infield and get right to joint surface shapes. And that's where we're going to close out our information. Okay, so now we will talk about joint surfaces, and that's going to help lead us into the last parts of what we're going to deal with. So joint surfaces, dealing with the shapes of joint surfaces. So the book tells us the types of the type of arthrokinematic movements that occur at the joint. So we're talking about what's happening at the joint, not the descriptive motion. So if this is my hip and I'm doing this motion, we call that motion abduction. We would agree? It looks like the hip is going out, that's abduction. We're not talking about the abduction. We're talking about the movement of the femoral head inside of the acetabulum. That's arthrokinematics. What's happening here details what's allowed to happen here. What happens proximally up here in the joint, the connection of the joint, details what's allowed to happen distally. So abduction has to happen here in the joint before I can see it here distally as an osteokinematic motion. Does that make sense? So joint controls distal motion. So proximal controls distal. What's happening at the joint details what's happening below, or details to what extent it's allowed to happen below. So the abduction of the hip doesn't happen unless there's some kind of movement here in the joint first. Arthrokinematics controls osteokinematics. That's a good way of thinking about it. Arthro controls osteo. Okay, so it says joint surfaces are either ovoid, sellar, or flat. Most synovial joints are going to be ovoid. So ovoid is going to be, let's see here. Yeah. So ovoid is dealing with oval shaped. It's going to look like this, like the ball of the femur. Ovoid. Ovoid. Okay. Bless you. Okay. So ovoids is going to have a rounded component. Bless you. So they're going to have a rounded component joint like the head of the femur. And then there's going to be a surface for the rounded surface to fit into or to articulate with. Ovoid. Ovoid. So these are primarily, most of the joints in the body are ovoid. It's going to be rounded surface and then a space for that surface to fit into. Sellar joints are saddle joints. So we already showed you what that looks like, where they're going to have two areas of, it's going to have a combined area of round and what we would call convex and concave. That's ultimately the term we want to get into. So let's get you, let's go all the way back here. Show you the saddle joint. Yeah, so that's the saddle joint. It has a portion that's convex and a portion that's concave on the same bone. So convex, the two ends are convex, the middle is concave. So here, convex, convex, concave, and then convex, convex, and then in the middle, concave. That's a sellar joint or saddle joint. It's going to have both convex, concave portions on each bone. Whereas in ovoid joint, one bone is going to be convex, the head of the femur, that's a convex, means a round shape, and then concave, a shape for it to fit into. So ovoids, one surface is convex, round, one surface is concave, like a cave, something fits into it. Convex, concave, that's ovoid. Sellar is going to be when we have two surfaces on each bone, one convex and one concave surface on each bone. So, and again, we don't have very many sellar joints in the body. The thumb is the primary sellar joint in the body. Okay. And then flat joints are going to be found in the hands. Don't worry about the flat. So just primarily think of ovoid versus sellar. Either it's going to have one convex, one concave surface, or it's going to have a combined convex concave surface on each bone. So those are the two different types of joint surfaces that we're going to be covering. And that jumps us all the way over, don't worry about open, close, pack position, to the convex concave relationship. That's where I've been trying to get to all day. Convex concave relationships. Okay, so the book tells us joint surface shapes, whether they are convex or concave. So we're dealing primarily with ovoid joints when we're talking about convex concave relationship. Will determine the arthrokinematic movements that are available at each joint. So it's going to tell us how the movement will occur at the joint via the convex concave relationship. So it says the convex concave rule describes the direction of arthrokinematic movement during osteokinematic motions. So the descriptive motions that we're able to do have to have arthrokinematic motions happening that permits that motion to occur. Without what's happening here at the joint, there is no movement distally. If I lock this femur head into this acetabulum, there is no movement below. Does that make sense? So I have to have arthrokinematics, joint movement, so that I can have osteokinematics, abduction, adduction, flexion, extension, internal, external rotation. So the motions that we see, that we can describe, happen because we have a good relationship arthrokinematically at the joint itself. So we have to have joint motion to allow for functional motion below. The rule states that a concave joint surface, let's do this. The rule states that a convex joint surface will glide or move in the opposite direction of the movement that is occurring osteokinematically. So when convex moves on concave, the motion, the arthro and osteokinematic motions are going to be opposite. So that's what we're going to take from there. I'll get that in a second. So, okay. So, we have let's see here. Arthrokinematics. Let's put arthrokinematics. Okay, so when we have it looks like a G. Convex on concave. These two here will be opposite. Okay, so let's show you how to think of this in your mind, and that'll help you. So take your left hand, make it like a cup, make it like like you're making a C. This is your concave surface. We agree? Looks like it shapes inward, right? Doesn't shape outward. Okay, take your right hand, make a fist. So fist and glove, fist and glove. Okay, so your fist is a convex surface. We agree? It's not flat, it's convex, it's round. Okay, so put your convex surface on your concave surface. Okay, now you're going to move your distal end of your elbow is going to be moving in a direction. And you're going to observe what's happening here at the joint between convex, concave. So if we're moving and our arm is going out like abduction, what's happening to your hand? Is it going the same direction as your elbow, or is it going the opposite direction? Opposite. The hand is going down, the elbow is going up. Or if we want to put it in descriptive terminology that we would use as it relates to people who learn kinesiology, the convex surface is moving inferior while the distal surface is moving superior. Make sense? So if one is going inferior, the opposite end is going inferior. So when convex moves on concave, arthrokinematic motion here, this is arthro, is going to move opposite of osteokinematic motion, what's happening at my actual elbow. So what's happening here goes opposite of what's happening there. So arthro and osteokinematic move in opposite directions. When we're dealing with convex moving on concave. But what happens if I switch it? What if I move concave on convex? If I do that, then the motion of arthro and osteokinematics move in the same direction. They move in the same direction. So let's take our hand again, form the glove, form the fist, and now this time the glove is going to move on the fist. So this time we're still going to be moving the elbow superior toward the ceiling. What happens when you do that, moving the glove on the fist? Do they move in the same direction or opposite direction? Same. This is going superior up and above. This is moving superior toward the ceiling. They're both going toward the ceiling, moving together. So when I move concave on convex, I'm getting same directional movement, arthro and osteokinematically. But when I'm doing it, with moving the convex on the concave, then I'm getting opposite directional motion. Okay? And that's going to help us to identify what motions are relevant when we start to understand osteo and arthrokinematics. Because we're going to start diving into that. There are some descriptive terms that happen at the joint that we're going to get into. I don't think I'm going to present that for this test at this time. But we will get into it next semester when we start talking about joint play, joint mobility, things like that. Okay, so let's cover a couple of conditions. We'll get you out of here. So common pathology, dislocations, subluxations, arthritis, sprains and strains. And we've covered sprains and strains already, so you're halfway there. So we're here on 55. Dislocation is a complete separation of the articular surfaces of a joint from disruption of the support surface, the joint capsule, and the ligament. This is when there is a complete separation of the joint. So this is an elbow joint here. This part of the elbow should fit around this, but you can see it's pushed backwards off of that, so it's dislocated. It's not located exactly where it should be. This cup part should cup around the end of this bone here. But because it's further back, something has happened traumatically that has dislocated the bone. This is another opportunity to see that there. It's a nice, lovely finger. You can see the dislocation. The finger is wrapped around where it should not be. That's pretty cruel and gross. Oh yeah, make you feel better. Dislocations. The next one is a subluxation. So it's a partial disruption in the tissue. So it's similar to a dislocation, but it's not fully removed from the joint surface. It could just be overly stretched. And so that's what you'll see there. The top of the humerus, or the top of the bone of the shoulder, should be right here where the arrows are there. But you can see the top of the bone is here. That's what leaves the dent right in here. So the dent that you're seeing there is the subluxation component. This little dent area here is sublux. The head of the bone is right here versus being up there. And that can happen. Sports is a lot of times what sublux stuff. You get sublux shoulders all the time. People slamming into each other, football. Okay. Osteoarthritis is a condition where we have a breakdown of the cartilage, and we showed you that. So the term that goes with the breakdown of cartilage over time is called osteoarthritis. The breakdown of the hyaline cartilage that covers the end of bones of a synovial joint. So if you have a synovial joint, it's a breakdown of that articular cartilage. And you'll be able to see the difference. So this is the picture on the right is a healthy normal knee. You can see the space in between it. That's where the menisci are, or the fibrocartilage discs that help to provide that joint space. That's a healthy knee. Versus this picture here, the meniscus has disappeared, and now they're rubbing bone against bone. And remember, we said if bone rubs against bone, it's going to cause breakdown. That articular cartilage is going to start to rub itself into a breakdown. And that's what's going to eventually cause us to have to repair this joint because of that space difference right in here. And that's osteoarthritis in a picture. All right. Yeah. So, and that goes well. And that, yeah, we'll get into inflammation in another section. But osteoarthritis. All right. So that is the final material for our final exam. Again, it will house information from chapter 1, dealing with the planes and axes. So I need to put that on there. I forgot to put chapter 1. So chapter 1, planes and axes in chapter 1. Chapter 3 that we covered, it's not a big chapter. Chapter 6, which we finished a couple of days ago, not a huge chapter. And then chapter 4, which we just finished today, the quiz was on chapters 1, chapters 3, and chapter 6. So if you did well on the quiz, you've already started processing information from those chapters. We'll just have to add chapter 6 and then the abbreviations, the symbols from the abbreviations. So I'm not sure how many questions will be on there. There'll be enough where it's relevant. I'll try to get, usually the final usually should consist of about 100 questions. I don't know if I'm going to write that many, but I'll write enough where you'll get a good assessment of your abilities. Again, that's a week from today. So that exam is a week from today. We will do it here in the classroom. Then after everybody is finished, we'll do our presentations. And then you are done with us until spring 2025, if the Lord says the same, for us to meet here again. So, any questions? Yes, ma'am? I can do that. That's a good question. It's a relevant question. I'll take care of that. Yeah. Any other questions?
For the abbreviations, you want us to do, you want us to study ones that you like assign to it as an assignment?
Right.
I just want to check, because I know you're
Yeah.
supposed to get updated one.
No, you don't have to learn the whole thing. No, just the ones that I put on the assignment for you to know. Yep, those will be on there. Just the ones from the assignment. All right. There's there's nothing else, it's been a great time. So your test will be in Rosenbaum. If you want to head over there and study. Once you're finished, you can come back to the classroom. We'll be meeting with the recruiter at 11:30, but we'll wait until everybody's done with your test before we start the presentation component.
Oh, so that's you?
Yeah, the recruiter will be in this class.